My name is Valerie Newitt, and I am a medical writer and editor with Advance. And today I will be the moderator of the presentation, which will be starting very shortly and will be presented by Dr. Stephen Hare on the use of biomarkers in the emergency department to aid in assessing high-risk patients. This webinar is sponsored by BioMarkers. Now I'd like to more fully introduce our presenter. Our presenter is Stephen Hare, MD. He's a graduate of the University of South Carolina Medical School and Palmetto Richland Memorial Residency Program. Dr. Hare serves as chairman and medical director at Morton Plant Hospital in Clearwater, Florida. In addition, he's the chairman of Pinellas County EMS Medical Advisory Board and co-chair of the SEPSIS Committee for the Morton Plant Emergency Department. We're very happy to have you today, Dr. Hare, and at this point, I am going to turn the presentation over to you.
Excellent. This is Dr. Stephen Hare. I am the medical director of the emergency department in Clearwater, Florida, and it is a beautiful day here, sunny and 88 degrees. I originally grew up in Ohio, as mentioned, trained in Columbia, South Carolina, and then went here to Morton Plant Hospital and have had one job my whole life at this tremendous hospital, very supportive. So today we're going to talk about the use of biomarkers in the emergency department to aid in assessing high-risk patients. First we're going to talk about sepsis, then we have a surprise at the end as well. So here we go. So this is the emergency department in the hospital that I work at. As mentioned, it's sunny here today, and that picture is obviously not taken from today. That was from sometime between 2008 and 2014. We really got involved in treating sepsis and formed a committee, realized what a deadly challenge it is and how we had to face it head on if we wanted to conquer it. Sepsis is costly. It's estimated at $17 billion per year. $50,000 is the average cost of treating sepsis. 40% of the total ICU expenditures result from sepsis. It increases the hospital length of stay and the ICU length of stay. Severe sepsis prolongs the patient's stay in the ICU and the hospitals by more than 50%. Sepsis is deadly. Obviously, that's why it's important that we attack this disease. 10th leading cause of death. 215,000 deaths per year. Sepsis is very difficult to diagnose. There's so many different other clinical presentations that present in similar fashion, and I'm going to touch on those later on. Sepsis can present with as a GI bleed or as a seizure patient. The SIRS criteria are very non-specific and present in many patients independent of sepsis. Microbiological proof of the infection is often negative or the availability is delayed. And 10% of the patients do not receive prompt antibiotic therapy, increasing your mortality by almost 10 to 15%. This is one of my favorite slides, and it's the slide in which you realize that sepsis really is a combination of what is known as SIRS and infection. SIRS are the criteria that we use to determine whether someone may have sepsis. SIRS includes a temperature greater than 101 Fahrenheit, heart rate greater than 90, respiratory rate greater than 20, white blood cell count greater than 12 or less than 4,000. So as we screen folks in the emergency department on a clinical basis, you do their vital signs, you then suspect that they may have infection. If they have that combined with 2 or more SIRS, then they're considered to have sepsis. If you find a hint of end organ dysfunction, elevated liver enzymes, elevated creatinine, then you have severe sepsis. Septic shock now is severe sepsis plus hypotension despite getting fluid resuscitation. And hypotension is qualified as systolic blood pressure less than 90. The other case in which you have septic shock is when a lactate is greater than 4. And that can be a little bit challenging, and I'll show you some of the examples of why I say that later on. Now, this came out of the Society for Critical Care Medicine consensus back in 1992. Sepsis review, disease progression. Patient comes in, they have some type of bacterial, viral, fungal, parasitic infection. SIRS criteria kick in. Fever, heart rate, respiratory rate. Progressing to sepsis with at least one acute organ dysfunction being severe sepsis. Then multi-system shock, septic shock, and unfortunately, death. However, there is the Grim Reaper, the 10th leading cause of death, as we mentioned, sepsis. It's a common cause of organ dysfunction, increased cost of care, and increased length of stay. However, what if we had something to find out early recognition, not focus on treating, because the bacteria will change, we'll have to come up with new antibiotics, but what if we could recognize it early on and make sure that we're getting the appropriate treatment early? Would that help? What if you knew that quickly that the patient had a bacterial infection? Additional piece of clinical assessment was available to help you with the risk assessment. You had a 20-minute test that's elevated in the presence of severe systemic bacterial infection. We have some biomarkers in the emergency department. Patient comes in, they complain of cough, shortness of breath, fever, chest pain. And to this day, I've yet to have one patient come in and tell me that I have sepsis. Please check me out. So you need biomarkers. You need some clinical markers to help you determine that. With cardiac patients, you have congestive heart failure, you have a pro-BNP, or you have a troponin that's elevated in a heart attack. With respiratory factors, there's infectious. They're either viral or they're bacterial, in which a PCT would be elevated, or perhaps a non-infectious state, such as a pulmonary embolus and looking at a D-dimer. The ideal biomarker objectively is measured and reproduced. It's an indicator of a normal physiological process, and it will be reduced in response. It predicts clinical events, and it's quickly obtainable and reproducible, and obviously has to be affordable. As we mentioned, some commonly used biomarkers include troponin, and there's the EKG, the BNP with congestive heart failure, and then procalcitonin, which is elevated in the site of sepsis. PCT is available and present in healthy tissue. However, it increases with infection. When there's infection, it is produced greater within the body by various organs, including lung, liver, kidneys, and adrenals. And they are highly suggestive of bacterial infection. It's produced by numerous organs, as we see at cells levels after there's inflammatory response. With septic conditions, the PCT rises in about 3 to 6 hours. The half-life is about 24 hours. And as mentioned, it's an early indicator of severe systemic infection. Procalcitonin is more specific for the diagnosis of sepsis. PCT does not replace lactate, nor does it compete with lactate. It helps provide a more clinical assessment of the patient. They're complementary assays. Please remember this. PCT is more specific. It is a measure of infection. Lactate sometimes is a measure of a shock marker, such as cardiogenic shock, hypovolemic shock. Procalcitonin, as we talked about, is made in healthy individuals at very low concentrations. Increased, again, bacterial infection. It may be elevated in other cases such as neuroendocrine tumors and non-infectious inflammatory states. I have yet to see this condition take place. Sepsis is a multidisciplinary approach to healing the patient. It cannot just be accomplished within the emergency department. It has to be a team approach. We engaged our hospital, again, a great system that is invested in helping patients and saving lives. We had a series of meetings, including the ICU team, the doctors, the nurses, the unit clerks, the respiratory therapy team, the emergency department team, the physicians here, the hospital administration, and created a screening tool, and we launched our sepsis plan several years ago. Interestingly, the guidelines have changed recently, and I have incorporated the new thought process. In the past, when a patient was found to be in septic shock, a central line was needed. Some studies showed that wasn't necessarily had to be done. You could use large IV lines and continue to give the patient fluids, but fluid resuscitation was absolutely necessary. So within our system, this is what we have to be completed within 3 hours at the time of presentation. Measuring the lactate, obtaining blood cultures, administering broad-spectrum antibiotics, and administering 30 mLs per kg for hypotension or lactate greater than 4. And this is what is the Surviving Sepsis campaign. In a moment, I'll show you what our campaign goes through. That's the 6-hour bundle, and the 6-hour bundle includes either applying vasopressors for a mean arterial pressure greater than 65, a lactate greater than 4, and remeasuring the lactate if the initial lactate is elevated. Then either doing a repeat focused exam to show that the patient's fluid status has improved, or measuring a CVP, SCVO2, doing a bedside cardiovascular ultrasound, or assessing the fluid responsiveness with passive leg raise or fluid challenge. And again, these are the surviving sepsis latest and greatest guidelines. Serial lactate measures may guide therapy. Normal is less than 2.5. Mild acidosis is 2.5 to 4.9. Moderate 5 to 9.9, and severe greater than 10. On the right there, you can see the mortality associated with each. Again, PCT is an early marker for infection, bacterial infection, and it's complementary to lactate. In severe bacterial infection, it does rise. The higher the risk, the higher the PCT, the higher the risk to the patient. Lactate, on the other hand, is a later marker. It is a severity marker in septic shock patients. It responds quickly to fluid resuscitation, and as mentioned before, it's part of the sepsis resuscitation bundle, which CMS is now implementing. PCT, less than 0.5, low risk for infection, greater than 0.5 to less than 2, moderate risk. These are folks that you're starting to look at and wondering, well, should I admit this patient to the medical floor, maybe telemetry? What other aspects are going on with this patient? Greater than 2, you know that this patient has some type of infection. There's a high risk for progression to severe systemic infection. These patients are going telemetry to the ICU. Greater than 10, that's high likelihood of severe sepsis or septic shock, and significant consideration on appropriate placement of that patient in the ICU is thought about at that point. So this is our checklist. Time of arrival, patient comes in. Do they have 2 SIRS criteria? The temperature, the heart rate, the white blood cell count, altered mental status, glucose that is high in a non-diabetic. We go above and beyond the Surviving Sepsis campaign mandated. I always want the best service. I don't want the minimal service that's required. I want the best for my patients. I want what is right for my patients. CBC has done a CMP, coags, procalcitonin, lactic acid, and a blood culture. The 3-hour benchmark time, giving the antibiotics, 30 cc's per kg, and of course notifying the charge nurse and the nurse taking care of the patient. And then we call a sepsis alert if their lactic acid is greater than 4, the blood pressure less than 90, or the MAP greater than 65. Less than 65, I'm sorry. So these posters are stacked all around our emergency department. The 3-hour sepsis goals, it's got to be posted everywhere. It's got to be in your face. It is in the physician's lounge. It's even in the restroom coming out of the lounge. Blood cultures, 30 cc's per kgs, antibiotics, using the sepsis order set, and that you are responsible if these goals are not met. This is one of my favorites as well. This actually is a clock that we made that we put outside of the door of the patients that we find to be septic. And we use the 3-hour sepsis thought process. We dial the clock, and that way the care providers can see what the time frame is, what we need to get done. We get the lactate, we get the procalcitonin, the blood cultures, the antibiotics, the fluids, and then at a 6-hour, you see there's a 6-hour one there as well, we repeat the lactate. Now hopefully those patients are up in the ICU or upstairs by that time, but unfortunately with challenging situations, sometimes that's not always the case. The sepsis alert process, we use team member stat paging. The primary attending, they have 15 minutes to call back, and they also page the intensivist on call. If they don't return their call, then we initiate a sepsis call matrix where there is the intensivist on call and they inherit that patient. We do consider putting in central lines, measuring the SCVO2 and CVP. Respiratory is also advised if their assistance is needed. And then the AOD tries to find the most appropriate bed in the hospital for this patient as well. These patients are treated with the same significance as stroke patients, as MI patients, anything along those lines. Early recognition is the key to diagnosing and treating and that is going to result in fewer inpatient days, ICU days, and cost of care, and save more lives. PCT adds to an early recognition and assessment by providing a host response to a severe bacterial infection. Lactate is a late marker. It's of perfusion and shock. Both of them are important. I believe I have a few case studies. Case study number 1. This one is very interesting. It's an 88-year-old male presented via EMS with a history of seizures, was recovering in rehab from a hospital stay for new onset seizure, past medical history, they had a seizure. Other diagnoses include hypertension, past surgeries, appendix, social history, no tobacco or alcohol. Patient had a seizure prior to presenting the emergency department, presented in the emergency department slightly post-ictal. Temperature 99, respiratory rate 21. There's a SIRS criteria. Heart rate 102, another SIRS criteria. Blood pressure 130/70, O2 sat 99% on room air. Physical exam, he's awake, he's alert, he's unaware of that he had a seizure, he denies any preceding symptoms, has 2 SIRS criteria, so labs are initiated. This gentleman, there could be an infection. He had a seizure. BMP is normal, CBC is normal, UA is normal. Lactic acid is 5.3. Procalcitonin is less than 0.5. According to the Surviving Sepsis campaign, this patient has septic shock. So, treatments, antibiotics, fluid, sepsis alert, ICU admission. These are the challenges that you're faced with. Please go back to the last slide. These are the challenges that you're faced with many of these patients that have SIRS criteria that potentially could have infection. And that's where a clinical judgment, along with the use of PCT, can help you assess these patients and properly treat them. 78-year-old nursing home resident presents secondary to just not acting right. This happens quite often. It's been going on over the past 12 to 18 hours. Fevers of 103, nausea and vomiting, has CHF, dementia, coronary artery disease, past surgical history, pacemaker. Temperature 103, respiratory rate 25, blood pressure normal, heart rate's high, O2 sats 88% on 6 liters. So we've got SIRS criteria. They're confused, they're tachycardic, they have rhonchi when you listen, some slight edema, given Solu-Medrol and a breathing treatment, and a liter of saline. Patient with no improvement, ultimately intubated, white blood cell count 26,000, BMP is normal, sodium's 130, BUN 51, creatinine 2.5, urine's normal, PCT of 14. That's pretty high. Lactate of 3.9. So we're qualified. There's a chest x-ray. Severe sepsis. Patient with severe sepsis, not septic shock. The lactate was 3.9. Given IV antibiotics, blood cultures obtained. Obviously, the patient going to the ICU. Next case, 58-year-old presents with not feeling well for 18 to 24 hours, weak cough and nausea. Past medical history is negative. They are a smoker. Temperature 102. Respiratory rate's okay. Heart rate's 110. There's your 2 SIRS criteria. Physical exam, tachycardic, rhonchi, and dry. White blood cell count, 18,000. Sodium, 131. Lactic acid, 2.4. PCT of 4. Kind of in the in-between stages here. Pneumonia with severe sepsis. Again, not septic shock. Lactate was normal. Obviously, the overall goal is to reduce mortality in the patients that we have the privilege of taking care of and using appropriate tools to diagnose and guide our treatments. Really is kind of the future there of what we're looking at. We talked about sepsis and how lactate is a shock marker, could be with cardiac or hypovolemic, and that PCT is used as a complement to lactate in identifying those patients and perhaps properly placing them. And then we had a little bit of a look at the future. And I would entertain any questions at this time, and hopefully everyone enjoyed the lecture today.
Thank you, Dr. Hare. That was really a very interesting lecture. We do have a question here. The question is procalcitonin a replacement for the lactate test? Is it a better test?
It is complementary to lactate. I find that is more specific, certainly for bacterial infection, and some of the slides that we put up there throughout that showed that. But the Surviving Sepsis campaign, which is used by the CMS mandates that you check a lactate, and it does have some value, as we mentioned, and is complementary in guiding your therapy, not only in treating the patient, but also in the placement of where they would be within the hospital.
And the questioner also asks, why would some patients develop sepsis from bacteria infection and not others? Are there any underlying issues?
Certainly comorbidities, congestive heart failure, diabetes, a reduced immune system, an elderly patient. Those patients are much more susceptible to sepsis.
We have another question popping up here. Would hospital labs have a way to measure PCT?
That's what we do here at our facilities within BayCare. Yes, they measure the PCTs on site, and the results are back within 30 minutes.
And also, what about sed rate?
That is not something that is incorporated into our bundle at this time.
Okay. Let's see. I have a question here. It says, is the 3 hours listed in the CMS protocol?
The 3-hour bundle that I put up was from the Surviving Sepsis campaign, which my understanding is what the CMS has adopted. It was previously, well, there's also a 3 and a 6-hour bundle. It was previous where the 6-hour bundle required you to place a central line for a patient that had a lactate greater than 4 or hypotension. However, after different studies went on, including the ARISE trial, and I believe the other was the PROCESS trial, they changed that belief in which you did not have to put in a central line. You could give the patient adequate fluids and measure through other avenues that the patient received appropriate IV fluids.
Attendee said, in your first case study, the lactate was elevated and the PCT was normal. What was the conclusion? Not
the patient did not have infection.
Okay.
That's a very good question, and again, that brings me back to a lot of different patients that present with abnormal vital signs. And when you're in the emergency department, you don't have a crystal ball to find out what that patient's going to have 2 days later. So unfortunately, you have to start some therapy because there is suspicion for infection. The patient, I think, in that case had a lactate of 5.9, and they had a procalcitonin of less than 0.5. So that's a very good question, good insight.
Another question is saying our hospital is actually looking at a 1-hour protocol, which seems impossible for the lab. What do you think?
Agree. Agree. Yeah, that's. There are so many patients that do have these abnormal vital signs. So unless you have a lab that was in the emergency department and you had nursing that was perhaps 2 to 1, getting a 1-hour process like this is nearly impossible.
I think you may have touched on this earlier, but we have a questioner asking, how long does it take to do the PCT lab?
About 30 minutes, and 30 to 45 minutes. I think it's more towards 30 when they actually run the specimen and the results are back.
And what is the sample for PCT?
It's a blood sample.
Okay. Let's see. Our PCT results are not available until the next day. Should we still do them anyway?
Yes, you should. However, you should ask your hospital administration to consider having them done in a more timely fashion so patients can be treated more appropriately.
Do you repeat lactates on all patients or only patients with a lactate greater than 4?
It is required by the bundle to check if it is greater than 4. If it is less than 4 and they're in the emergency department, personally I do not recheck them. However, the patient may go upstairs and have it rechecked by that admitting physician.
Now, this person actually continues, and you may have answered this. Are you going to repeat in all patients or greater than 2 with the new core measures as of October 1st?
Again, that would be the upstairs physician's decision, but most likely yes.
Okay.
And if the PCT is elevated, obviously you don't want one point on a graph. You want to see that you have some response to treatment.
Is there any FDA-cleared POC device for procalcitonin that you know of?
Not that I'm aware of. Very good question.
Certainly have a lot of questions coming in, Dr. Hare.
Nice.
Yeah. Other than bacterial infections, what else can elevate the PCT?
I went through a couple of those on the slide. Neuroendocrine tumors, I believe burn patients, bacterial endocarditis when it's subacute. Although I did see a case of bacterial endocarditis. It was not subacute. This gentleman, unfortunately, was in septic shock fulminant, and the PCT was elevated. But there was one of the slides that we went through that talked about that.
What would you personally consider an acceptable PCT turnaround time from a lab? I mean, we know what your lab does, but what would you think would be acceptable from any lab?
My top decile would be half hour to 45 minutes. My median, an hour and a half to 2. And then anything after that is starting to run into that kind of 3-hour time where you want to make some decisions on these patients. So, however, there is value, even if it's after that, in obtaining a point on a graph, if it is a send-out, that you still obtain that point on the graph, recheck it the next day, and see where that point on the graph is as well.
What about a POC test for lactate? Are you aware of anything that's good?
Yes, that does exist.
Okay.
It tends to be falsely elevated. At least my gestalt, my clinical care that I give, we find that we are rechecking them in the main lab, and sometimes that they are slightly elevated.
How would you respond to those who claim PCT lacks sensitivity to drive decision-making in suspected sepsis?
I would argue that that is incorrect. PCT is absolutely one of the markers that we use with lactate in identifying the septic patient and treating them with antibiotics as quickly as possible.
You said earlier that the sample is blood, and a questioner says, is the blood sample serum or plasma?
That's an interesting question from a physician standpoint that I can't answer because I don't go down to the lab. I would imagine that it's serum because there's no point-of-care testing that is available, but I don't know the answer for that one.
Oh. These questions keep coming in. Are you game for a couple more?
Sure.
All right, what is the point of blood culture in the 3-hour response? Do you get data on this within 3 hours?
We do not. However, that is the bucket that CMS has chosen to use with that Surviving Sepsis campaign. That is one of the check boxes that you have to obtain the blood culture prior to giving any antibiotics, and that has to be done within a 3-hour time period.
Has PCT been used on patients meeting less than 2 Sears markers?
Yes.
And can you use either, but follow-up should be on same sample? I'm not understanding that question. I'm sorry. How do you perform the lactate measurement?
Blood sample.
Okay. And what is the lactate critical value range? Has it changed with the new regulations?
4 is still the kind of scary point, greater than 4, where you consider the patient to have septic shock. And 2 to 4 then would be towards more of the severe sepsis when there's end organ damage.
Another questioner is asking, what about tourniquet use in sample collection, especially prolonged tourniquet time? What about delays in sample testing with iStat system? The questioner says she believes lactate increases 1% per minute of testing delay due to observations at her facility, and she's wondering if you have any comment on that.
Yeah, that certainly may be correct, but from my standpoint, that's really not a question that I can give a great answer to. It's more of the clinical aspect. But yes, my understanding with the tourniquet overuse with it staying on a long time with the blood not being run in a timely fashion, that can elevate your lactate.
Okay. Well, that's pretty much it for the questions, and you certainly did answer a lot, and we certainly thank you for that, Dr. Hare. And I want to thank you again for such an informative and excellent presentation today. Well, again, I want to thank our presenter. I want to thank all of the people who have been with us for this broadcast. We appreciate your activity and your engagement and your questions. We hope you'll come back and do more webinars with us here at Advance. And of course, I want to give a special thanks to our webinar sponsor, BIOMARKER. We greatly appreciate their support and making this happen for everyone. So with that, I again bid you farewell and thank you for joining us. And I will be ending this broadcast momentarily. Goodbye, Dr. Hare, and thank you very much.
Goodbye.